So today, we're going to dive into a really critical new diagnosis that has some major implications for clinical practice. It's called prolonged grief disorder, or PGD. We're going to break down the evidence from some landmark publications in the Lancet and the New England Journal of Medicine to see exactly what this means for patient care. Okay, so to really get a handle on this, let's start with a real-world clinical puzzle. Imagine this. A 55-year-old woman comes to you. It's been 18 months since she lost her husband, but her grief, it's still just as intense. She has this persistent yearning for him, she's withdrawn from her friends, and she's even having suicidal thoughts. So this case presents a critical question, right? Are we looking at recurrent depression? Is this a very difficult but still normal grieving process? Or is it something else entirely? To answer that, we really need to understand what PGD is. And that means looking at how it recently became a formal diagnosable condition. You see, this is a huge step, because it acknowledges that for some people, the natural process of adapting to a loss can get, well, it can get derailed. If you look at this timeline, you can actually trace the journey. We went from using terms like complicated grief, all the way to its landmark inclusion in both the ICD-11 and the DSM-5-TR. And what this formal recognition really means is a huge shift in thinking. It's the culmination of decades of research confirming that for some people, the natural healing process stalls and turns into a distinct clinical condition that needs its own specific attention. Okay, so this is where it gets really interesting. When we compare the two main diagnostic manuals, we see they both agree on the core symptom, this persistent, intense yearning for the person who died. But there's a critical difference in the time criteria. The ICD-11 sets the bar at 6 months, while the DSM-5-TR requires a full 12 months. Now, this isn't just a technical detail. It has direct, real-world implications for when we can actually make a diagnosis and, more importantly, when we can start treatment. So once we have these criteria in mind, the real challenge for any clinician becomes precision. How do we tell PGD apart from other conditions that can look so similar on the surface? This brings us to the absolutely crucial task of assessment and differential diagnosis. This table lays out the key distinctions beautifully. Normal grief, as incredibly painful as it is, tends to come in waves and usually lessens over time. Major depression, on the other hand, presents with a more global sadness, feelings of worthlessness. But PGD, that's different. Its hallmark is a stalled adaptation. It's all centered on that specific, unrelenting yearning for the person who was lost. Now for a practical assessment, clinicians do have tools they can use. Something like the 5-item brief grief questionnaire can be a really quick way to screen for patients who might need a closer look. But the gold standard is, and remains, a thorough clinical interview. That's how you really confirm the diagnosis and tease apart the core issue. For example, you might ask, do you feel your life is empty without the deceased, which gets at PGD, versus a more general question like, do you feel hopeless? And of course, it's crucial to know who's most at risk. This helps us know who to watch for. While PGD might happen in about 3 to 10% of people after a natural death, that rate jumps up significantly when the death is unnatural. We're talking suicide, homicide, or an accident. We should also be on higher alert when the loss is a child or a partner, or when it was just completely sudden and unexpected. Okay, so we know how to identify it. Now, the big question, how do we treat it effectively? Well, this is where the research has actually given us some very clear guidance. The good news is that multiple randomized control trials have made this really clear. Specialized grief-focused psychotherapy is the first-line treatment. Things like prolonged grief therapy, or PGT, have been shown to have moderate to large effect sizes. And here's the crucial part. These therapies work better than standard treatments for depression when you're dealing with PGD, because they're designed to target the specific mechanisms of that stalled grief. So what about medication? This chart is key. It's from a major trial published in JAMA Psychiatry. Just look at the left side. For the core symptoms of grief, there was no significant difference between the SSRI citalopram and a placebo. But if you look over on the right, you can see citalopram did significantly reduce the co-occurring depressive symptoms. So the takeaway here for clinicians is crystal clear. Right now, there are no FDA-approved medications for PGD itself. And while antidepressants are absolutely vital for treating any co-occurring major depression, we have to be honest with ourselves and our patients. We can't expect them to fix that core symptom of intense yearning that really defines this disorder. All right, let's bring it all together. How does all this evidence shape a real-world management plan? Let's go back to our patient and lay out the key clinical pearls. So, returning to our case, the diagnosis is clear. She has prolonged grief disorder with co-occurring recurrent major depressive disorder. The management plan discloses directly from the evidence we've seen. First, you refer her for the first-line treatment, prolonged grief therapy. Second, you optimize her overall medical care. And third, then you can start an SSRI to specifically target the MDD and the suicidality. The goal here isn't to just move on. It's about integrating this profound loss into her life. So, to wrap all this up, here are the 4 big take-home messages. 1. PGD is its own thing. It's a distinct clinical entity, not just a severe form of depression. 2. Watch the clock. Those time criteria, 6 to 12 months, are absolutely essential. 3. Therapy is first line. You need grief-specific psychotherapy. And 4. Medication is for the comorbidity, not the core grief itself. And this all leads to a final, really important question for all of us. Now that prolonged grief disorder is formally in the books, with clear criteria and evidence-based treatments, how does this change our collective responsibility to identify, to validate, and to effectively support those who are experiencing this kind of profound, debilitating loss, both in our clinics and beyond?